Good afternoon. Welcome to today's webinar. I'm Natalie Oates, Vendor Member Concierge here at IBPSA. Carmen Rustenbeck, our CEO, is actually driving right now, and because she's going in and out of service range, we may or may not have her on with us today, but we're just going to forge ahead without her. We are joined today by Tracey Keiser again of the Keiser Group. They are working diligently and overtime to help us get set up with our first ever association health plan. Tracey's going to bring us up to date and provide another quick overview of the type of coverages that will be available to you. As we go along, if you have any questions, you can find the question box over on the right-hand side of your screen. I will monitor those, and if I can answer it as we go, I will. Otherwise, we'll just hop back on with Tracey at the end and go through the questions. Also, we are recording today, so if you need to go back and re-listen, you can do that within about 24 hours or so, and the video will be available on your member dashboard. I think that's all I need to get us started. So Tracey, welcome.
Thank you, Natalie. It's always a pleasure to be with everyone. And some of you on the webinar today may be folks that we've already talked with, and that's exciting as well. So hopefully we'll have some finalization and some additional details here on the webinar to help you in your own planning. As we wire down, and for those of you who we have not worked with yet, there is still time, of course. I recognize that we all have an exchange deadline of December 15th, but remember that's not really a deadline for January 1. Effective dates for group plans, that's really for the exchange, that's more the individual side of things. And so that deadline is certainly in conflict with group health deadlines. And so just as Natalie and I were talking earlier today, it makes sense for anybody out there who might be an individual or have some individuals, if you're worried about the deadlines and coming into plans in the 11th hour, it makes sense to go ahead and go online, fill out your application on the exchange. Remember, you don't have to pay for anything till January 15th, so that gives you plenty of time to see whether or not the group plans through the IBPSA are a good fit, or if you're wiser to be on the exchange. And so with that, just want to kind of give everybody a little bit of peace, because there's always a panic in the air this time of year. And certainly the television and everything you hear on the news and web and so on about Obamacare increases that tension and anxiety. So, but just everybody needs to relax and just remember that there's always a way around that. And go ahead and fill out your app if you're in limbo, and you can let it sit there. If you decide to go with group plan, it just goes away. And if you decide not to, then you have it in place and can go ahead and pay for it as you get into January. So we'll jump into plans here as well. Many of you, or those of you who already know or we've already been working with, trying to get the mouse to work here, know that the state approvals have been coming in rapidly. And they started really last Thursday, Friday in terms of finalization. Prior to that, it's a lot of back and forth with the state governments, because even though the federal government approved AHP plans, as we spoke about in our first webinar, recognized that the states still govern the insurance language and components and have statutory requirements and so on for everybody in an association plan. And so anybody who's in one state and then someone who's in another state, obviously we have to communicate with the states independently on your behalf, meaning on behalf of the plans. So those state approvals have been coming in quite rapidly, and we expect that every single one of them will be completed here this week. Most all of them were in by Friday. Any questions that they asked or refinements they needed, et cetera, have already been resubmitted back. And as Natalie mentioned, our staff's been working overtime, which you guys are working overtime in your business as well this time of year. So that's not anything to be concerned about, but are definitely doing a lot of work back and forth with the states to make sure that they are completely satisfied and your association passes all regulatory requirements. So the deductible options as a standard, know that the great advantage, certainly in working in any association plan, and as I've had the opportunity to talk with many of you, we've obviously had conversations about how excited everyone is and have been waiting for these association plans to come out and be a part of your opportunity for benefits, because the exchange has become quite expensive. And I was talking with someone recently, their benefits had gone up from $500 a month as a family in 2015 to $2,600 a month as a family in 2018 on the exchange. And so that's the pricing has just become out of control. So as a standard, and here's where you kind of wrap your head around, what to think about in the medical side. There's everything out there from the very high deductibles to the low deductibles, the HSAs, everything in between. So as an association structure, the standard options will be the $1,500 gold deductible, the $3,000 silver, the $5,000 bronze, and the qualified high deductible health plans. The qualified high deductible health plans are what you know as catastrophic plans. They are for the people that are up to age 30, and they don't cover much on the front end, but they're just simply for catastrophic purposes. We have incorporated more front end transactions into those plans to better help the employees, but that's what a qualified HDHP plan is. So just know that's the standard offering. Now, as we work with each of you on your plans, you will have other options beyond those, but they will all revolve around those major options of deductibles. The question has come up quite often. Should I use a low deductible? Should I use a high deductible? We've talked in the previous webinar about gap strategies. We'll talk a little bit more about that today so that you have the opportunity to strategize. It oftentimes makes more sense to choose, for example, a $5,000 bronze plan, then incorporate a front-end gap plan. So you, in essence, eliminate the front-end deductible component, and you can put that in at any rate, $1,500, $2,500, et cetera. And so therefore, as an employee, you would have the first $1,500 or $2,500 paid by an insurance product, and then the second $3,500 or $2,500, depending upon what you chose, would be paid by you. And then, of course, your insurance goes into co-insurance after that. So avoiding a $5,000 out-of-pocket deductible is easy to do with a gap strategy. Oftentimes, as I was mentioning, it makes more sense to do that than go all the way down to a $1,500 gold plan. That may be quite a bit more expensive, but in each of your situations, we'll evaluate those options, evaluate the strategies, and show you multiple ways to use your money the best, most efficient way possible. Co-insurance options as a standard will always be 80-20 versus you see again all over the board 90-10s, 50-50s, and so on. 80-20 is an industry standard. It lends itself to being reasonable, affordable, manageable for most folks. And so an 80-20 is where we'll stay for the ease of administration and certainly for the ease of implementation for all of you as members. The copays, and copays are things that, are $10, $20, $40, et cetera, and you don't pay anything else. And those are for your PCP, means primary care physician, your specialist, and your urgent cares. Those are all standard copay scenarios. And of course, those will be in all of your plans. Your prescriptions, all plans will have 3 tiers of prescriptions. And then, of course, your 4th tier, which is your high expensive specialty drugs, are rather than just being voided or not available, if you will, those fall into pharmaceutical subsidy category, where we access the pharmaceutical subsidy coffers, if you will. I guess that's the best way to say it, but the pharmaceutical subsidies that are available to the members to actually help pay for those expensive drugs. And those are the real expensive, crazy specialty drugs that are out there. They're ranging anywhere from $4,000 to $100,000 a month for newer drugs that have been developed, more expensive care, et cetera, unique kinds of situations, and so on. But your 3 tiers take care of the great majority of everything that occurs in the pharmacy side of everything. There's been a lot of questions about part-time employees. Can we do anything for part-time employees? Do we want to do anything for part-time employees, et cetera? And there's been depending upon where you are, there's a general consensus out there that it makes sense to do as much as you can for part-timers, because all employees, good employees, are hard to come by these days, and even good part-time employees are hard to come by. And so what we're seeing is a trend in your industry for people to provide part-time benefits at the expense of the part-time employee, because oftentimes they're a second income, for what we call an affordable transactional medical plan, which really takes care of those front-end copay type situations, doctor's office visits, specialist visits, urgent cares, prescriptions, things like that, and some minor benefits for other CT scans, MRIs, things like that. And the reason that it's there and the reason why that becomes a valuable plan is many of your part-timers do have high deductible healthcare plans through the exchange or catastrophic plans, which means they typically do not have anything for the day-to-day things that are happening in their lives. And so to incorporate an affordable transactional type plan gives them that front-end coverage if it's something they want to pay for themselves. The dental plans, vision plans, life plans, gap, accident, and catastrophic plans are all available to your part-timers at the same level as your full-timers. Your part-timers would have the tremendous advantage of your group rates in addition to your full-time employees. And for gap, that can be incredibly, well, it can be important for everything, but for the gap strategies, even if they have their health insurance with a spouse, happen to be a part-time or full-time person with you, but with their spouse or on their own, they have a high deductible, they may want to choose a gap plan through your employment so that that takes care of the deductible for them with their medical plan that they have somewhere else. So there's a lot of different strategies that can go on to assist your employees. What's also important from an employer standpoint is that you have a pre-tax advantage, meaning the deductions are taken pre-tax, so your payroll taxes are reduced slightly. Your employees' payroll taxes are reduced slightly as well. So your medical plans, dental plans, vision plans, gap, accident plans are available. Premiums are able to be redirected pre-tax. Life insurance and catastrophic or critical illness type plans cannot. As we move into the part-time plans, and a lot of people have asked, well, gosh, what are all the things that it covers? Even though I mentioned those things just briefly, just know that this gives you a little bit more extensive outline of what a part-time affordable transactional plan would be for your part-time employees. And then, of course, when we start looking at price points, everybody's anxious to be looking at price points, of course. The medical affordable part-time plan, or for somebody that opts out of your medical and just wants something for day-to-day, not to be confused with a full ACA-compliant medical plan. But the affordable part-time plan is, again, just a segmented product for a very specific purpose. Rates are obviously very inexpensive, comparatively speaking, might be even slightly less depending upon your state. This is the high side. But your plan 1, meaning a lower plan, is $72.10. Your plan 2 is $91.40. At the high side, again, could be slightly lower depending upon your state. Children, spouse, et cetera, are available if somebody has a need for that type of thing as well. It's important to remember that your medical plans, your traditional medical plans, which we talked about in the first slide, are the plans that are ACA or Obamacare compliant. Those keep everyone as an employer compliant if you're over 50 employees, keeps everyone as an employee or individual member compliant with the federal government. It's important to know that as of January 1 of 19, an individual no longer has a penalty that has to be paid for not being compliant with the government. However, that said, the law has not gone away. So even though the penalty has gone away through the executive order that President Trump put out, the law still stands. And so even though you may not have a penalty, you are still legally required to have coverage through Obamacare. I know that sounds crazy and it sounds like it's in opposition with each other, with both sides, and it is, but it is the reality. So I want to make sure everybody's aware of that. I don't want you to be afraid that you have penalties anymore. Not to say anybody can't go back and make them retroactive. I'm sure they could. But at this point, the announcement and the notices have gone out that there's no penalty being charged to the members. Medical gap, we'll talk about it just a little bit more here because it is such a critical component to help reduce cost, because you can go to a higher deductible and then fill that front end with a gap plan. The components, obviously, inpatient, outpatient. We all know there are always two components of everything we do. Inpatient components are hospital, surgical, physician, and then outpatient, surgery, diagnostic, physical therapy, and durable medical equipment. Just going in and out of the doctor's office for a doctor's appointment certainly does not fall under gap because you have a low copay, and that's not part of your deductible anyway. Going in and out of a specialist office has a copay, so that's not a part of your deductible. So those two components are certainly not, or urgent care, certainly not in your gap plan because they're already accounted for in your medical plan. And I recognize that this can get a little tedious and a little institutional in terms of discussion and in terms of subject matter, of course. And because it's not interesting subject matter, I know it can also be a little bit boring. So hang with us a little bit. This will be a little bit shorter webinar than some of the others, of course, but the information that we're working through here is important information for everyone. And because you can go into your library and pull that back down and listen to it again, you can also, I'm sure, print out the slides. So it makes it easy to use as a reference point. Embedded medical gap plans for employees only. If I were going to a $5,000 deductible, for example, and putting in a $2,500 gap plan for myself as an employee, I might save several $100s by doing that, and I would pay $46 by putting in a gap plan. So my savings would be greater than going to a lower deductible plan. And that's the concept. Again, we work the numbers every time we evaluate a plan to see if it's better one way or the other. But just to give you a feel for price points as well. And of course, those of you in family plans, $110 to reduce costs by $500 or $600 is a small price to pay. And of course, the gap benefits are for every member of the family that's on the plan. So if it's just one of you, that's great. If it's 5 of you, then everybody has the same benefits as well. The 2,500/1250 means this: 2,500 for inpatient, 1,250 for outpatient. So your outpatient, so really it's a 3,750 gap strategy. 1,250 for your outpatient expenses, 2,500 for your inpatient, because your inpatient really relates more to your deductible than your outpatient anyway. As we get into dental, and many of you have dental plans and they're all over the board. Some of them are indemnity, some of them are only paying at the 50th percentile, and lots of out-of-pocket expense balance billing, things like that. As we spoke about in the previous webinars, I want to reinforce here as well, is that the dental plan through your IBPSA will be one of the very, very best in any of the markets that you're in. It will be the most comprehensive dental network because it has 3 networks overlaid on top of each other, so there's virtually no dentist that is not in the network. And of course, all payments are in the 90th percentile. What that means is when you have a bill, it's $100, you can expect that $90 of that $100 will be covered by insurance and is approved by insurance. You see a lot of plans out there, won't name the names, of course, that don't tell you anything, but they may pay at the 50th, 60th, or 70th percentile, and then you have a big balanced bill from the dentist after the fact. You want to stay at 90th percentile and above. Always ask that question of anybody who presents you with dental insurance. And of course, many times the dentist just assumes the 90th percentile as full payment. So rate tiers, of course, 4 rate tiers, and it's important to have 4 rate tiers so that you really have the best rating advantage versus lumping everything into employee or family or employee plus 1, et cetera. This gives you the best rating advantage across the board. So you'll see the different plans. Unlimited annual max for those folks who say, gosh, I'm going to have a lot of dental work. I don't want any maximums on my plans. I just want it to be unlimited. And I want 100% coverage for my preventive. I want 90% coverage for all my basic services like tooth extractions, et cetera, cavities. I want 60% coverage for all my major services like root canals and so on. Those price points are incredibly attractive and competitive in any markets that you're in for that kind of a benefit portfolio. As soon as you get into other maximums, $1,500, and again, a reduction in benefits, and of course, a $1,000 maximum and a change in benefits as well. You'll find a lot of times that your younger people want to do only a $1,000 max, and they don't want to pay for major services because they, in their own mind, and it's pretty accurate, feel they don't necessarily have to have root canals yet. They don't have dentures. They don't have any of the major things that happen just with time and age. And so they can choose a very, very low cost product and still get 100% coverage for all their cleanings, all their checkups, 80% for all their cavities, all that sort of work that has to be done, which gives them incredibly comprehensive coverage, but they're not paying for the high level expensive root canals and things like that. You also can put multiple plans in your group. So if you have, several employees, you can have a high plan, a low plan, and people can pick and choose from there. So it serves both sides of the coin. Then as you get into vision, your vision plans are the same way. High network, so you have both of your individual optometrists as well as your retail stores all available, and virtually no optometrist that is not in the network as well. Taking both your VSP and your iMed networks and putting those all together, which are the two biggest networks in the United States today. Your frequency, when it says 12, 12, 24, you may remember that means you can get an eye exam every 12 months under the coverage, glasses, frames every 12 months, and lenses every 12 months, frames every 24 months. And when you look at Plan 1, for example, it says 10, 10, 160, $7.19 a month, very, very inexpensive. What that means is when you go to the eye doctor, it's $10 for your exam, $10 for your frames, and $10 for your lenses, and $160 allowance for your frames. And again, we apply that same formula over to Plan 2, $10 for your eye exam, $15 for your lenses, $130 allowance for your frames, and of course it's reflected in the rate. So regardless of part-time, full-time, those are incredibly affordable rates for anyone, and particularly because everyone is pre-taxed, you have another small amount of tax taken off of that cost. So a $4.55 expense can end up being $4, which is less than, as we all know, a stop at the McDonald's or somewhere down the street. Life benefits, I won't go through the life benefits. We did that before, but certainly life is available to your full-time and your part-time folks, and certainly limited capacities at the employer level to provide for everyone, pennies on the dollar, of course. And many are applying $10,000 life for their full-time employees, and then allowing part-time and full-time to have voluntary life coverage. That is certainly available for everyone. And again, based upon the whole group, pricing is there, established for the entire group. And so as we move through life, again, I won't go through all the different life coverages because the life coverages are dependent upon what person chooses and what their physical age is, aside from the employer providing life coverage across the board for everyone. So as we've wiring down this year, of course, and it is December 12th, though it feels like it's December 20th for everybody, I'm sure. And I know you're busy as well as the insurance industry. It's the busiest time of the season for the insurance industry as well. We've obviously been communicating with an awful lot of folks. If we have missed you for some reason, please notify us at ibpsa@thekeisergroup.com so that we can make sure to accommodate you and expedite your details. The intention is never to miss anyone, but anything can happen when you're working with databases and so on. And so we just would ask you to please let us know right away. Aside from that, if we've already had discussions with everyone, we've already gone through revamping and revising your census information, and of course have gathered, in some cases, medical questionnaires and so on, then you're in the next process is to distribute your plans back to you with multiple options, multiple rates, multiple strategies. And we'll be doing that as quickly as possible over the next few days and into next week, and quite frankly, into the end of the year, based upon everyone's deadlines. Just because there's a lot of questions that come up about deadlines, legally, of course, you can always enroll in a January 1st plan until January 12th. Though we don't encourage that, we don't ask you to do that, and we don't believe we'll have any plans that go past the first of the year for enrollment. But we will be working pretty expeditiously to make sure that happens, because there has been a tremendous outpouring of interest from the members at IBPSA as well as members of other associations. And so there certainly is a lot of volume that everyone's working on. So I'm not asking everyone to have patience. I am just saying that you won't be left behind, and we won't forget about you, and you won't miss deadlines or lose coverage. But if you feel at all uneasy, as we spoke about early in the webinar, please go ahead and fill out the apps on the exchange just so you have something in place, knowing that you don't have to pay for it until January 15th. And that gives you that safety net if you feel like you need that as well. We are expecting, and this is not anything we can guarantee, but we are expecting that when rates are finalized for each and every employer group, that they are about 20 to 30% less than what you're seeing on the exchange. So that gives you a little bit of something to budget from. And from a medical standpoint, using middle of the road, not high deductible, not low deductible, we always ask everyone to kind of plan on, in your own mind, thinking about $450 to $500, $550 as a range of rates. Now, they could be lower into the 3s and 4s. They could be higher into the 6s and 7s based upon low deductible, high deductible selections. But it's always wise to be thinking about that price point to keep yourself kind of focused on a budget that's actually workable for you as an employer, and certainly for your employees as well. A lot of questions about contribution modeling. Excuse me for coughing. From a contribution standpoint, we don't see many contributions out there that are less than 50%, and in some states, the state requires 50% or more contribution from the employer. And so for your budgeting purposes, always think about contributing 50% of the medical plan for your employees. We also don't see many employers anymore that are paying for full employee, spouse, and children coverage. There may be contributions, but in the smaller employer environment, we see virtually no contributions there. So again, just as a point of reference, a lot of people have been asking, what's everybody doing? So I'm just sharing this in bulk for everyone. From most of the time, the employees are taking full responsibility for the cost for their spouse and children. And that can be quite expensive, as we all know. So just kind of think about that from a budgeting standpoint as well. Dental, vision, all the other benefits other than life, if you want to layer it for everybody, can be employer contributed, employer paid, or completely employee paid as well. And there is no right or wrong there. And it's really all over the board in terms of what everyone is doing. It really depends upon how long you've been in business, really, to know where your budgets allow your expenditures to be. And those of you who are new in business, obviously the budgets are not as wealthy, if you will, as the ones that have been in business a little bit longer. And so for those employers, you can certainly start with employee paying for all or a portion of benefits as it relates to the dental and on down, and certainly 50% of medical. And then you can grow from there. Question came up yesterday. A gentleman asked me, am I wise, because he wanted to pay for everything for his employees, am I wise to do that, or am I wise to have them contribute? General consensus always is people value something they spend money on. And so it is always a reasonable expectation that an employee would have some level of contribution for any level of plan versus just be paid for by the employer to get the maximum appreciation for that plan. There are oftentimes employers have gone out and paid for their benefits in full and then are frustrated by the fact that the employees don't really understand the cost, and so they don't understand the value and don't appreciate the value as much. And so some things to think about, and that's just more planning and strategizing on your part than on ours, that aspect of everything, of course. So you really know your population better, certainly than we do, and you know what you're trying to accomplish short-term and long-term, more so than we do, of course. And in many environments, of course, employees are hard to come by, and so there are some concessions that you may or may not have to make depending upon what your recruiting environment really looks like. But it's been a pleasure talking with all of you, and probably most of you on this call, throughout the last few weeks. And it seems like the last couple of weeks, of course, have been a nonstop with all the association members, which has been really interesting and pleasurable to work on these plans with all of you. But as we enter into this next phase, and thank you for everyone who's been returning all their information, but as we enter these next phases, it will be a quick response time to choose plans, to then work through the enrollment process with employees, and of course then all documents that have to be signed and so on, so everything can be uplined for January 1. Enrollments are a unique situation, and we can certainly conduct the enrollment with your employees for you by telephone or in person if the size warrants and the timing allows. It's not as wise or not as beneficial, if you will, if you're looking for participation. We find that when employers oftentimes go out to their employees and ask who's interested, the employees typically don't respond as favorably because they want the employer to pay for more of it. And so oftentimes an employer takes the approach of, I'd like to have a neutral party actually conduct the enrollment, survey the employees. There's a few other things I'd like to ask, and we can incorporate that into enrollment, and then feed back to me what the results are from the employees. We can certainly do that if that is your preference. If your preference is to do it yourself, that certainly can be accommodated as well. And so I want to just extend that because that's always the point of confusion. Should I predetermine as an employer who is interested and who is not? You know, not really. All full-time employees, if you certainly make things available to one full-time employee, you have to make it available to all full-time employees just to maintain proper discrimination activity, non-discrimination activity, let's put it that way. And so we need to make sure that everybody who is full-time is then eligible for coverage. Same thing with part-timers. If you allow part-timers availability, then all part-timers should have availability of some of the benefits. We would also recommend that you incorporate an eligibility period. Some employers have not had benefits before, so it's been kind of a new subject matter. And that would generally, as a standard, the standard in the United States is typically first of the month following 60 days after the hire date. So if someone were hired today, that would mean 30 days is January 12th, 60 days is February 12th, they would be eligible March 1st. And you can certainly go down first of the month following 30. I would never recommend that anyone make anyone eligible any date other than the first of the month, because in an industry that has movement and turnover, it can cause you to have to manage benefits every single day of the month, and that is the last thing that you need to spend your time doing. So the first of the month following 30 or 60 days makes the most sense, and then we're only managing eligible employees on that first of the month for benefit availability. So again, just some education to help anybody on the webinar who might not be involved in benefits currently, or who might not really understand what they're doing with eligibility, or are growing so fast they haven't had to think about eligibility in the past, but really do as you go forward. Always a recommendation in the first month following 60 days, because most turnover happens in that first 60-day period, if it's going to happen, in any kind of fast pace. And so that helps you with alleviating a lot of paperwork, a lot of on and off coverage, things like that. So with that, Natalie, I'm certainly going to turn the webinar back to you. And if there are any questions that have not been answered, let's throw those on deck to see if we can get everybody an answer.
Great. Thank you, Tracy. We do have a handful of questions here that I think we can run through pretty quickly. The first one is the sample rates that you were showing earlier. Are those per month or are those per pay period?
No, thank you for that question. Those are always per month, and those are total rates, not an employer or employee split or anything of that nature. So you would take that number and then manipulate it how you might like to manipulate it for contribution, and that is a monthly rate. Great.
That's what I thought, but I thought I'd ask and make sure. Another question about providers for contact lenses. I believe you talked about the wide range of providers in the vision program. Is that correct?
Yes.
Okay.
And yeah, go ahead.
Would that include the contact lenses by mail?
Yes, absolutely. And let me expand upon that. For the purpose of a webinar, it's always truncated information. Once you get your proposal information, we'll have all of that included. But when you look at $160 allowance for frames, for example, typically that allowance goes right over to contacts as well, whether that's in a doctor's office or by mail. If contacts are medically necessary, someone might have macular degeneration or cataracts or something that a contact product would be necessary for them, that immediately defaults to medical insurance. And that question's come up quite a bit when I've talked with various people. And so, just so you know how vision works, vision is for all your normal eyesight scenario. Anything that goes into medical goes over to your medical plan. But so if you have a vision plan that has, for example, $160 allowance, then that will be your allowance for contacts. And if they become medically necessary, so they're not going over to that other side of the table, if you will, then there is no limit to the allowance. And generally then what you have is an unlimited allowance.
Okay, great, thank you. Another question, are the medical rates age-based or are they composite pricing?
We'll be working with composite rates all the way across the board for all the medical plans for IBPSA, which is actually helpful for most everyone. And it also helps you from a budgeting standpoint for the future, because you know what you're working with from a rate standpoint. So everything that we'll be working on, regardless of the state, unless something crazy happens in the last minute where a state says, oh no, we're going to require age banding, which we don't anticipate that yet. We've already been down all those paths. Everything will be composite rating, and you'll have an employee rate, employee spouse, employee child, and then family rate.
Okay. And then the last question that I have here so far, unless somebody else has another one they want to pop in right quick, is can we still put money into an HSA?
Absolutely. An HSA is a standalone uh, tool, if you will, that you do not have to use through a carrier or any other service. You can actually have that as a standalone tool for you as an individual or for your business. And you can use that with any medical plan you have. You can also take that with you wherever you go. So that is a very long-standing, asset, if you will, that you have for yourself. And if you have a current HSA with a current plan, and as you transition over to a new plan, we'll help you transition those HSAs as well.
Great. Well, Tracey, we are so happy that you've been able to join us over these past few weeks to help educate and guide us through this process. I know Carmen, as she's driving in her car, is shouting thank you as well. Folks, if you have any questions, you can still email Tracey at any time. I know some of you are still turning forms in. Tracey, thank you so much to you and your team for your hard work on trying to pull this together for us with all of these deadlines and everything. We really appreciate it. And I believe this is going to be our last visit for the year. So again,
it
if
is
you
on a webinar, though we will, it is certainly our last webinar, but we will be interacting with all of your members through the email address here on the screen. And so we would ask them, please don't hesitate to communicate, even though there's no ongoing webinars.
Right. So, and I think that's all we have. So thank you all very much for being with us today, and we hope to talk to you all soon. Bye-bye.
Thank you, everybody. It's been a pleasure. You bet. Thank you, Natalie.
Mm-hmm.